Okay, so our next speaker, I think, really needs no real introduction, but I've got a lot of really nice things to say about her, so I'm going to say them. So, so Professor Helen Cross is going to speak to us next about paediatric epilepsy surgery pathways, referral processes, and waiting times. So Helen is the Prince of Wales Chair of Childhood Epilepsy and Director of UCL Great Ormond Street Institute of Child's Health, as well as an honorary consultant in paediatric neurology at Great Ormond Street Hospital and at Young Epilepsy as well, I should mention. So her research over years has been targeted at improving outcomes in early onset epilepsy, specifically in addressing the role of surgery and ketogenic diet. She's had lots of amazing leadership roles and 2 weeks ago completed her term as president of the International League Against Epilepsy, like the proper international, the whole international thing, which is absolutely amazing. I'm sure it's been a lot of work and she will continue to be involved in their board for a few more years. She's clinical advisor to the National Children's Epilepsy Surgery Service. She developed the European Reference Network for Rare and Complex Epilepsy, something known as EpiCare that a few of you may be involved in. She's got loads of publications, more than 400 it says here, so I'm sure a lot more than that. She's received lots of prestigious awards, including the ILE Ambassador for Epilepsy in 2017, and received an OBE for her contributions to childhood epilepsy. In addition to all that, she's a brilliant clinician, been a great mentor to me, and I look forward to hearing her speak about this. Thank you.
Thank you, Elsa, for that kind introduction. It's always a bit daunting when someone says we don't need to give an introduction, because there'll be lots of people in the room who don't know who I am, so that's absolutely fine. So I've been asked to talk about epilepsy surgery, and here we go. And so to talk particularly about referral processes and waiting times, and this has been a topic of discussion amongst particularly the NHS. It's been one of the streams to the NHS Children and Young People's Epilepsy Transformation Programme. So we've been trying to collect some data, look at what the barriers might be to referring for epilepsy surgery. And I think I'm going to discuss some of the problems we've had with this, not least where have the guidelines been, which I'll come to at the end. My disclosures. So I'm going to talk a little bit about what is epilepsy surgery, and then talk about what are the expected outcomes. We now have a lot of data on outcomes from childhood epilepsy surgery, and really have a handle that it's a way to go. So then a bit about what does pre-surgical evaluation entail, just to give a bit of a background. Introduce the Children's Epilepsy Surgery Service, then look at referrals and expectations. I will get there. Are we doing what we should be? And then look a little bit at the barriers. So what is epilepsy surgery? And I put that diagram there. It's very crude. That is not what it is. But it's the removal of or modification of part of the brain with the aim of alleviating seizures. Our primary outcome aims are seizure freedom, or at the very least, seizure reduction. Although many families who come to us have other aims, not least neurodevelopmental or learning gains, and of course, behavioural improvement. Our overall premise is that we do no harm. This is an elective issue, so it's well planned, and the whole premise is that we are going to make the individual better and no worse. So children are investigated to determine where the seizures are coming from, and is it safe to remove that area with regard to what they can do. And therefore it requires a multidisciplinary evaluation, and it needs to be part of a comprehensive epilepsy service. And this is where I've come in over the past 20 years. Children require very specific consideration. They are not little adults. So just a few scans, not brain pathology, to explain what epilepsy surgery is. So types of surgery we can have that we may talk about and that comes up in the slides is if there's a small area of the brain that we want to remove, then we call that a lesionectomy. If it's slightly wider over a part of the brain that we call a lobe, there are 4 lobes on each side of the brain, then we call it a lobectomy. Some children come to us for consideration of a whole disconnection of one side of the brain. In these children, they already have an abnormality of that side of the brain. No function is thought to be undertaken there. They already have a weakness on the opposite side of the body, and that's a hemispherotomy or it's a hemidisconnection. Some children who have widespread problems in their brain may have drop attacks as a particular problem, and in those we may divide the two hemispheres. We don't remove anything, and this is a corpus callosotomy. And this is the spectrum of what we tend to see. So essentially, this was a survey that was undertaken a long time ago, but it was trying to emphasize that what the range of procedures we undertake in children and indeed the range of pathologies we see. And it was undertaken in 2004. It was worldwide, looking at 20 centres that were undertaking epilepsy surgery at that time. And it was looking at procedures undertaken over a 12-month period. And it was determined that many of the procedures that we undertake are indeed hemidisconnections or multilobar procedures. At the time, the main procedures undertaken in adults were temporal lobe resections. That's historically what epilepsy surgery has been. And the vast majority of pathologies that we were seeing were cortical dysplasia, malformations of cortical development. Something's happened to the brain in the development of the early development, and that area of the brain is abnormal. It's not the right structure. Have things changed? Well, this is the results of a study that we undertook across Europe. It's actually a pathology study. It's a European brain bank study, but actually looking at procedures undertaken across 36 centres, 12 European countries over 25 years. And you can see that actually the range of pathology for the pathologies, hippocampal sclerosis, which was the classic adult pathology causing focal onset seizures, the procedures for that have gone down over the years. Those for malformations of cortical development, or cortical dysplasia, have gone up over the years. And indeed, if you look between adults and surgery and children, adults are on the left and children on the right, you can see that actually the pathologies, the malformations of cortical development, the increase has actually been in the children, and there's actually been a decrease in surgeries in adults over that period of time. And indeed, this is another study that looked across 18 centres across Europe between two different decades, the 2000s versus the 2010s, and essentially 1990s, versus the 2010s. And it actually, reassuringly to us, as I'll come to in a minute, indicated that more children were operated in the second decade that they looked at. There was no real difference in the number of what we call non-lesional cases, but certainly an increase in non-temporal surgery, which is what you would expect from the fact that there were more children operated. The number of adults over that period of time in this study appeared to be the same. So what about outcomes, and what are we achieving? So if we look at, we're actually looking at children. This is just to illustrate, in some, can you see my mouse? Yes. Okay. In some where it's a hemidisconnection or indeed a localized brain abnormality. There has been a randomized controlled trial. Now, this is the kind of evidence that we talk about now when we're looking at evidence base. Have we got a randomized controlled trial? And you think, how can you do surgery versus no surgery? Well, this was actually a study that was undertaken in India, which had a very long waiting list. So they evaluated children, decided whether they were surgical candidates, and they were randomized to either have their surgery immediately or put on the waiting list, which was 12 months. Now, some may question whether that was ethical. A year to wait for epilepsy surgery is a long time, but that was the reality of their country. And you can see actually doing this, that there's no doubt that the surgery group, and admitting that this is a drug-resistant group, because that's one of the criteria of coming to surgery at this stage, the surgery group had significantly higher likelihood of seizure freedom at 12 months following surgery than the medical group by the time they came to surgery. And there's been a lot of observational studies over the time which have suggested that seizure freedom following surgery reaches about 80% at 1 year, and then dips at 2 years to around 60%, and then remains stable over that period of time. Now, that doesn't mean to say there's a further percentage that actually have improvement, but seizure freedom long-term is around 60%, and that doesn't matter whether you look at an adult study, whether you look at all ages, you look at children as the blue, it seems to be the same. So what about predictors of seizure freedom? Well, yes, it may be related to what the cause is, whether it's a nice circumscribed area that can be removed easily, or whether it's quite diffuse. It may be related to age. Children seem to have a better chance of seizure freedom in the long term than adults. It may be related to the type of surgery. But overall, if you take a statistical analysis, the best predictor is the shorter duration of epilepsy. So the earlier we do surgery, the more likely they are able to do better long term. And also, children seem to do better than adults. Now, you could argue this is seizure-free. There is a chart that looks like this, just looking at seizure freedom on or off anti-seizure medication at 5 years, and children do seem to do better than adults. This is seizure freedom and anti-seizure medication free. One of the aims often is to come off medication. So to be seizure and anti-seizure medication free at 5 years, the one on the left is children and the one on the right is adults. So it is much more likely in children that they're going to be seizure-free and anti-seizure medication-free at 5 years. Now, you could argue, well, children are more likely to come off medication because there's less to lose in a perception of some people because, for example, adults might be driving and they don't want to put the risk of having a seizure. But actually, it's a similar view if you look at whether they're remaining on medication or not. And what we now know also is cognitive outcomes, learning outcomes in the longer term are much better if we achieve seizure freedom and if they come off medication. So if we look at the chart on the left, the green line is actually those who became seizure-free following surgery. The dot is surgery. So you can see there's a bit of a decline in learning preoperatively and steady increase in the long term, not necessarily short term, but long term, in the learning, the cognitive ability in the seizure-free group, not seen in the not seizure-free group. And actually what we also see, the green here is off medication and the yellow is on medication. So actually the better outcomes are seen if they're not only seizure-free, but if they come off medication. So I hope I've convinced you that we might do some good with epilepsy surgery. What does it entail? Well, this is sort of a schematic of the evaluation protocol. Essentially, first of all, the clinical description of seizures is key. The recording of seizures with the EEG, the brainwave test, and the video for us to look at the seizures is key. A high-resolution MRI brain scan to look at the structure, and a neuropsychology evaluation to look at the learning ability. After that, we may make a decision after a big discussion that actually surgery is an option at that point. But then some individuals might need to go to further tests, further imaging, in order to try and determine where the seizures are coming from. And others, ultimately, we then make a decision whether, again, we could go for surgery. And this is the kind of decisions that either they're not surgical candidates, we may go straight to surgery, we may think, actually, there's more information required from something we call invasive EEG monitoring, or ultimately, or indeed whether we want to make sure that where the seizures are coming from are not too near something that's quite vital with regard to functions such as movement. When, over the years, there's always been a bit of discussion about where children should be operated on, or even evaluated, and ultimately decisions made and actually operated on. And this was a report that we undertook from the Task Force for Paediatric Epilepsy Surgery in the International League Against Epilepsy, where we actually undertook a process, a consensus process, because there's not any literature really on this, which we call a Delphi process, but it's where we raise a list of questions a list of statements, and then we look to a wide range of individuals, wide ranging in expertise, geographical base, in order to see whether we can reach consensus. And where there was more than 75% consensus, then we established criteria for epilepsy surgery centres. But actually, this just illustrates that there were very few. In fact, England, the KES service, actually had drawn this up, and I'll come to that in a minute, but very few other places around the world had got legislation as to what an epilepsy surgery centre was. So we utilised all these centres around the world, and you can see that every continent is represented, even Africa. There's a little red dot on the bottom, which is Cape Town in South Africa. And ultimately, we came up with 2 levels of centre. Level 1, which was older children. There was a minimum number of operations per year, very discrete lesions, and the types of procedure that could be undertaken. And the level 2 centre, which could include younger children, needed a greater number of assessments and indeed operations per year, a wide range of different etiologies, and indeed types of procedure. And particularly, you needed to be a level 2 centre in order to undertake surgery on individuals where you couldn't see the lesion on an MRI scan. So the Children's Epilepsy Surgery Service was initiated in November 2012. I snigger because it seems a long time ago. And this was where we went through, we advocated that we needed, this was a specialty service. We needed to train up the centres to do this. It was resource intensive, so it'd be much better if these children were evaluated in a smaller number of centres who could gain the expertise. And the whole premise was to try and improve access, actually, for children with epilepsy who could be assessed for surgery. There was never any advocacy that we wanted to improve outcomes because we had no evidence base that outcomes weren't good. The evidence base we had was that we weren't doing enough operations in the UK compared to what we thought we should be doing. So the 4 centres, after a full assessment process, were designated. There was London, which was Great Ormond Street Hospital with King's College Hospital in the Evelina. Norcas, the north of England Children's Epilepsy Surgery Service, which is Manchester with Alderhay. Bristol Children's Hospital for the southwest, and Birmingham Children's Hospital for the Midlands. As I said, the primary aims were to provide a multidisciplinary team review and assessment for children at that time with drug-resistant epilepsy, and to advise on the course of treatment and care, including surgery, in order to reduce epilepsy-related deaths, improve seizure control, and improve quality of life. And there was a whole variety of key roles for the National Service, not least to provide a multidisciplinary team review of all children who meet the criteria for evaluation for surgical intervention for their epilepsy, to provide a comprehensive pre-surgical evaluation for specified children, provide and coordinate epilepsy surgical procedures for children in line with the specification, to identify and support local care within the Children's Neuroscience Network, to provide expert advice to services, and to provide leadership for research, audit and training and management of epilepsy through surgical means. So a clinical pathway in the service specification was devised. And obviously, we need to integrate with all the existing pathways with regard to management of epilepsy. So, of course, the local management of epilepsy by the paediatricians with an expertise in epilepsy continues within local services, but that care would also be coordinated with tertiary paediatric neurology. And there has been discussion as to whether all the children should come through the tertiary neurology prior to being referred to lead clinicians in the designated KES service for their local service. I think there's been discussion because there's concern that perhaps there are still those that don't get through the tertiary neurology service, I'll be upfront, but ultimately the tertiary neurologist should be aware of the ongoing care and referral into the epilepsy surgery service. And then ultimately the referral is accepted, or there may be a decision at that point on review of preliminary data then actually they're not suitable for evaluation, but they are suitable for vagal nerve stimulation and indeed for tuberous sclerosis patients, everolimus. And then the surgical evaluation protocol looks very much like the one I have shown previously, not least the mandatory basic review. Then if that's conclusive, then they may be offered surgery at that point. And I would emphasize that this is a journey. We see the patients and the families initially, we talk it through with them, we go through with the evaluation, but there's constant discussion. This is not surgery is what you have to have. This is a two-way discussion and an agreement. And ultimately what we're trying to do is give whether surgery is an option, what the likely chances of seizure freedom are, and what the risks of surgery are, so that we can make a joint decision as to whether that's the way to go forward. We may do that after the basic evaluation, but if not, if there's still more detail required, then we may go through other testing. And ultimately, it may be that we end up still saying, no, it's not an option, or giving the option, or indeed there may be a need for invasive EEG monitoring. The one advantage of having a service that's 4 centres and we have a board that we come together on a regular basis, but all the specialties of the MDT, the multidisciplinary team, have come together on a regular basis to discuss. And so they have been able to produce consensus-based recommendations, for example, for video EEG monitoring with regard to pre-surgical evaluation in England. But also they've looked at outcomes, and this is the UK experience of steering EEG. We included Scotland in this. So, because this was the UK experience, not just the English experience, but again, giving outcomes and the trends over time. So this is actually just to give a sample. I mean, as I said, we didn't set the service up to improve outcomes, because we had no evidence that the outcomes weren't what they should be. But certainly we obviously need to audit our outcomes. And this was looking at our surgical seizure freedom outcomes. And you can see 12 months following the year 2016, 2018. So we looked at this, 17, we looked at this, just giving a 12-month outcome, as you can see from the Children's Epilepsy Surgery Service in the middle here. And this is, when we look at ENGL, this is a specific seizure outcome scale. So class 1 is free of disabling seizures, or essentially seizure-free, that's what we're looking for. Class 2, rare disabling seizures. Class 3, worthwhile improvement. Class 4, no worthwhile improvement. And you can see if you look at benchmarking against international, we're very similar, which is reassuring. However, the main key point of this is to, are we operating on enough? Are we seeing enough compared to what we think we should be seeing? There was this epidemiological study published in 2009, which actually came from data from Anne Berg, who recruited all newly diagnosed patients over a period of time in Connecticut in childhood and followed them longer term. This was 669 patients included in the cohort. And what they did, admittedly this is 2009, and actually the cohort was recruited much earlier, and they had MRI scans. So their MRI scans would not have been as detailed as what we do now. But they took all those that had structural abnormalities that could be suitable for surgical treatment to try and calculate how many per population could be surgical candidates in the longer term. And they calculated that actually 27 per million children would be suitable for epilepsy-related surgical procedures, so that would include VNS, 23 out of a million resective surgery. So on that basis, and acknowledging that this may be an underestimate, because it doesn't include MRI negative patients, and our imaging is so much better now than we had then, this is on the bottom is the calculations per region that we think we should be having referral and ultimately doing the surgical procedure. So you see from the southeast, we should be looking at about 96 procedures per year. This is what we're looking at per year. Bristol, 91, they're covering the whole of the southwest up to including Oxford and Southampton. Norcas, 97, covering the whole of the north of England, and Birmingham around 69. So a total number of procedures in England of 353 per year. That's what we should be aiming for. And looking at the number of referrals, you'd say all those with drug-resistant epilepsy, although I come in a minute as to whether we do wait for drug resistance, but that's another discussion. We're looking at 1,700, essentially, referrals per year. Looking at 2023-24, pre-surgical evaluation and number of CAS surgeries is on the top. Always when you take a snapshot, you have one centre that's not done as much as it's done before or afterwards. Birmingham had a change of staff here, so that's much lower than they had been doing, and they've picked up again since. But you can see that we're nearly there, although Norcas may be looking for more referrals, and we were operating on a 281. So we have been steadily, and as I'll show you in a minute, we've been steadily increasing. And this is just giving some background. 2023 to 24, this is the last complete year that we had at the time, looking for waiting times and waiting lists and the number of patients waiting, for example, for stereo EEG. And different centres have different challenges in order that may create bottlenecks. And this is something that we are evaluating all the time. And indeed, what we see here is really a snapshot of those that are waiting. But what I want to really point out is the number of referrals for surgical evaluation was 583 in 23-24. So this is referrals over time. And you can see actually, and just to point out, 24-25, this was evaluated last October. So it was April to September. So this, if you double, would be, I worked out 732. Which is what I would hope we would have seen. So we have seen a steady increase in referrals over time. And in fact, between 2016 and 23-24, centres, the referrals had increased by 45% over that time. So we'd achieved our primary aim. We began to get increased awareness and increased referrals. And this just showing evaluation, referrals, evaluations, surgical procedures, and surgical procedures as a percent of referrals. Because when we started this, we were thinking it may be a 1 to 3. You need 3 times the number of referrals to the number of surgical procedures. Now we're beginning to think it may even be 1 to 2, but you can see it's been pretty steady over time, around 40%. 2018, it was 50%, but we've been around 40%. 40% of those referred going on to have surgical procedures. And you can see at the end, using the 2016 and 2004 start and end points, surgical evaluations and surgical procedures, surgical evaluations have increased by 34% and surgical procedures by 14%. Now, there's a bit of a paradox here, because when we look at the epilepsy 12 data, and this is the longitudinal data or longitudinal trends that I've taken a snapshot of. You can see in the middle here, we've got epilepsy surgery referral. So this is looking at how many, after a 12-month period since diagnosis, I understand, and correct me if I'm wrong, Colin, how, over a 12-month period since diagnosis, were referred if they fulfilled criteria. And you can see that actually, it's not very impressive, the increase in trends over that time. Tertiary input is closely related to that, and that also, unfortunately, is relatively static over time. So we have a bit of a problem in the fact that we don't seem to get our children to the tertiary referrals. Yes, about 50% of them get to tertiary referral within that 12 months if they make the criteria, but there are 50% who make the criteria and don't get there. And why is that? I have to say, we've been discussing this, and how can we improve it? Do we have a resource issue? Do we not have the neurologists to actually see them? That may be the case. But I was looking through the NICE guidance, and these first came out in 2004. They were redone in 2012, but that was only for pharmacological management. So really, we've been going on our guidance since 2004, and there's actually not a mention of surgery. It's diagnosis and management of epilepsies in primary and secondary care. This is Clinical Guideline 137, as was. And there was a criteria for referral to tertiary care, but no discussion of epilepsy surgery. So I asked Colin, what did you use for the epilepsy 12 criteria? That was a bit of a problem, I think, initially. Is that right? For tertiary referral, I know you took it under 2, and so 2 of the directions here, under 2 years of age, and 2 anti-epileptic drugs have been unsuccessful. But for the surgical referral for surgery, what did you utilise previously?
Yeah, it's been the guidance for tertiary referral has changed.
Yes.
So we've the age range has gone up, and the addition of myoclonus in the under 4s has.
But in the previous iterations for referral for surgery,
it's been remarkably consistent, but it's been harder to know what to point to in terms of the criteria, because we've found that there's slight differences in pragmatics and criteria when you look at NICE guidance compared to the different centres and practice in the real world.
Absolutely, but but what I'm trying to argue is that we really didn't have guidance for who to refer for epilepsy surgery up until the 2022 NICE guidance.
Correct.
We had about vagal... Sorry to put you on the spot, Colin, in the middle of my talk. I did warn you. Vagal nerve stimulation. Yes, there's a mention of surgery, but it's the only mention of surgery. It said vagal nerve stimulation is used in children where they are not suitable for resective surgery. But because this is a guidance for primary and secondary care, there's no discussion of surgery. Whereas in 2022, we redid the whole guideline, and there is a whole section on resective epilepsy surgery. And for children, people with drug-resistant epilepsy, for children and young people, this should be to a tertiary paediatric neurology service for consideration of referral to a children's epilepsy service surgery centre. And indeed, where there's MRI abnormalities, there's clear guidance that they need to be referred for assessment. So I would argue that previously we didn't have clear guidance, you could argue. We now have clear guidance, and we need to advocate for that. And now also, this is actually the consensus view from the International League Against Epilepsy, where they discussed a whole paper, because there is an issue, is if we have demonstrated that the only likelihood of cure in children with specified lesions that are easy to remove, I say easy, relatively low risk to remove, their only likelihood of cure in the long term, namely seizure freedom and coming off medication, is surgery. Surely we should be advocating this before waiting for a period of time for drug resistance. And indeed, the International League Against Epilepsy, referral for surgical evaluation should be offered to every patient with epilepsy as soon as drug resistance is ascertained, with no real age limit. Of course, that's not really relevant to us. A surgical referral should be considered for older patients with drug-resistant epilepsy who have no surgical contraindication. That's not really relevant for us. A surgical referral should be considered for patients who are seizure-free on 1 to 2 anti-seizure medications but have a brain lesion in non-eloquent cortex. And that means cortex, brain, where it's not governing any function. So what have been the barriers to referral? And it's quite difficult. I mean, I think, yes, you could argue the lack of guidance to individuals is one, and you could argue that tertiary neurologists have been left to make the decision. And I would hope that everybody was up to speed when they need to refer, but that may not be the case. These are the preliminary results of the survey undertaken in Open UK, which I think was 2017. Agreed? So this was just a survey that was undertaken through Open UK to see what general practice was through the network with regard to referral for epilepsy surgery. And so there was not a question, was there a formal local or regional pathway for complex epilepsy? Yes, in 46 replies. Yes, refer to visiting linked neurologist in 39. No pathway, only in 1. For the referral process for KES, they refer to the regional paediatric neurology team 40, the local paediatric neurologist 29, directly to the KES centre 24. Nobody was directly referring to a non-KES neurosurgical team, which was very reassuring. And access to procedures at non-KES centres, e.g. for VNS, yes, discussed with the KES centre, yes, without KES discussion, and that's contravening actual guidance, and there's 25 that said no. And barriers to referral, unclear how and who I refer to, something we needed to do something about. Funding cost implications, well, that should not be a concern because it's within the standard pathway. Identifying suitable patients, the identification of who is a surgical candidate should be at the KES centre. When in doubt, refer. There's no harm in referring too many people. We may moan we see too many patients. We'd rather see too many patients and find the surgical candidates than otherwise. I am unable to refer independently without tertiary neurology input. We recognise that may be a barrier, and that's something we have to do something about. No access to precursory investigations, that shouldn't be a barrier. They will be done at the KES centre. Proximity to nearest centre. The 4 centres were decided on geographically. There was a review undertaken of the specifications to determine from a PPI, patient public involvement point of view, whether there was a problem with travelling to centres, and the vast majority of individuals, families said, we will travel if we need to get the expertise. And patients or families do not wish to pursue surgery as an option. I would emphasise referring for epilepsy surgery is not saying surgery is going to take place. It's to discuss whether it's an option, and then families can, with the information that's provided, can decide whether it's an option they want to undertake, and they may still decide not to. But I would really encourage that the decision and the discussion needs to be taken at an epilepsy surgery centre, not necessarily locally, where, with respect, there isn't the expertise. There are many challenges for the KES centres, and we're trying to work through these, not least for increasing referrals. Well, that's good, but we need to decide on the resource to deal with that, and such things as theatre time, reducing pathway time. We need to make sure that we don't have people waiting once they're in a pathway and at any pinch point through the pathway. Database completion is an issue for us. We want to collect data, and having the resource to fill in databases can be quite an issue. But there's no doubt that with the increase in referrals, the increase in time, the increased investigations that we have available, the increasing expertise, we are seeing an increasing complexity of children. That can only be a good thing, but it also creates time required within the multidisciplinary time. We have moved with our invasive monitoring to what we used to utilise subdural monitoring, which was grid monitoring, through to stereo EG, which is actually much less problematic for the child, but much more time consuming for the team. Not least because then is more meetings that are required, more planning, more discussion time, and the surgery doesn't happen when the electrodes come out as it used to. There needs to be a rescheduling for another surgery. So there's a whole different pathway, which of course hasn't been catered for within the existing service specification, and we need to look at that and the resource required. And we need to administer ongoing local education to optimise our referrals, optimise the referral pathways, and make sure everybody is aware when and if to refer. So in summary, epilepsy surgery is an established management option for carefully selected children and young people. There is a lot of evidence now of improved seizure outcomes with shorter duration of epilepsy, and indeed improved longer-term cognitive outcomes in seizure-free patients. So we should be seeing patients and children and young people early. There is clear guidance now on who should be referred for assessment. Assessment does not mean agreement for surgery. Therefore, there's much to gain from an early referral. I challenge there is much to lose from finding out you're a surgical candidate 15 years into your epilepsy. Surgery gives a real option of cure for carefully selected children and young people, and much more better likelihood of good outcomes. Thank you very much.
Thank you so much, Helen. Great overview of what's happening currently in the UK and about the role of epilepsy surgery for the epilepsies. So any questions in the room while people are thinking, can I just ask about, because obviously because I'm in Scotland, Calvin, I'm not involved in Epilepsy12, a lot of discussion about that. So, but looking at the data that's coming through about the surgery referrals, it's a little bit disappointing, isn't it?
Yeah, it was. And, that's what we had a lot of discussion on. But as I said, you could argue how have we measured that? And one of my questions was, is that lack of referral to the appropriate place? How is it measured? And as I said, I'm not entirely, we didn't have, thank you. I actually, when I was reflecting on this, and even after we'd had the discussion, if we're basing this on NICE guidance, actually, it's only since 2022 that we've actually had appropriate guidance for epilepsy surgery. That said, we've been trying to advocate for referral, but it may mean that within 12 months of diagnosis, those referrals weren't being made.
Yep.
But actually, for referral to tertiary care within 12 months where they meet the criteria, that hasn't budged either. And that, I think, is probably partly a resource issue and partly an unaware issue at a local level.
Yeah, I would agree with that. Because looking at your Open UK survey, which is a few years ago now, but it sounds as if through your networks, you feel you are, the people who completed it felt they were referring on either to the tertiary clinic or to the link in the outreach clinic. So it does feel that we need to understand that barrier a bit better.
Yeah, and I haven't put it up here, but we can get geographical data as to where there are more referrals than others, and that's something we probably need to tackle.
Yep. Thank you. Any questions in the room?
So I'm here both as a personal person who has had epilepsy my whole life, but I also now work at Great Ormond Street, and so I turned my epilepsy into my career. I actually am someone who was never put forward for epilepsy surgery and was told as a child, now I am a bit older, so I think it was all very new, but told as a child that epilepsy surgery or anything was not an option and I wouldn't be seizure-free. I actually then, because of my work at GOSH, had to fight to be moved to a more tertiary centre and got given epilepsy surgery, and I'm able to say it was very successful for me, but I had it at 27 years of age when I was diagnosed at 11 months. So I think having been under a local kind of neurologist who actually told me I would never be seizure-free, all these things that was something I was asking about, I was never allowed telemetry. How do we, I respect that it's all improving now, but how much is there learning for those very local centres of kind of general neurologists to ensure that people like me, but kids, and obviously I now look after them on the ward, that they're not being missed and they don't get to 20, and if they're not fighting their own corner, then actually they're lost.
Well, it's a two-way thing. Partly it's education from our part and advocating on a regular basis. Basically all children should be under local paediatricians with an expertise in epilepsy and should be linking into their tertiary neurologists with epilepsy expertise. And I have to say, I would hope that we are making inroads to know that is, that those people know to refer on to for epilepsy surgery. But this is where there's discussion where maybe we should be allowing direct referral from the paediatricians with an expertise in case there are those barriers. And unfortunately, there are still those barriers. So, there's a two-way thing. We need to tackle it from a BPNA point of view, that's the British Paediatric Neurology Association, but also make sure we've got the right referral pathway. And I would hope also now with NICE guidance, that's there. The other thing is, of course, the trouble is parents are becoming more vocal, which is good, I'm not saying, and there's the internet, and there is the fact that they can ask for a further opinion. And I advocate for that when I hear about patients not being able to get through their local service.
And you are a great advocate for epilepsy surgery, but also about the barriers that you faced in getting to that point, which has obviously been...
As part of the study on cognitive outcomes, we looked at timing from diagnosis to surgery. And depressingly, over the 30 years, or 20 years, there hadn't been a decrease in time, but actually there was an increase in complexity of patients. So if you looked at our standard patients, I say standard, more straightforward, it's not very fair to say, but straightforward patients, the timing had gone down, not dramatically, but had gone down. It's just that the complexity of patients has also gone up. So if you look at it overall, it doesn't look. But, the thing is you're a case in point. A lot of adult studies have shown it's taken 15 to 20 years to get to epilepsy surgery. We should be doing it within 2 to 3 years. And that's what we've got to really push. We need to stop children with onset in childhood getting to adulthood with their epilepsy. That's the point.
I think especially your point about saying, like, if you get 15 years down the line, how much less of it. I'm very lucky to sit here and say that it's done very well for me. But actually, that's scary to think that there are people that they'll get down those 15 years and actually they might not get the outcome that they might have got a year or 5 years before.
And this is where I say refer if in doubt, because the people who need to make the decision whether surgery is an option are the CESS centres, not the local paediatrician who think, or the local neurologist who think, well, it's not in the right area, they won't be surgical candidates. I'm afraid there's a lot we can do to evaluate now, and therefore the decision should be made by the CESS centre.
So we want to avoid missed opportunities, for sure.
Hi, I don't know if this is...
It's
That's
working.
perfect,
Yeah,
perfect.
Yeah, it's working. I can hear you.
I'm a secondary care provider, large university health board in South Wales, so we have to go through the Welsh Assembly for our commissioning arrangements. In the same week that I'm asked to comment on them, I've got a child with focal cortical dysplasia. For a long time, I thought, I'm sure surgery is going to be great for you, and it is so frustrating seeing her come in and out of hospital, deteriorate in terms of her overall functioning. She's a mainstream girl. The length of time it takes. I know in adult services you've got to prescribe cenobamate to be even considered now.
This is in Wales.
In adult surgery, epilepsy surgery.
In Wales?
In Wales.
Yeah.
That's what I'm told. She's actually even on cenobamate, but it's not making any difference. What can I do as a secondary care provider? I am a little... We have wonderful paediatric neurology colleagues. They're great. They have got waiting lists. Neurophysiology resource hasn't been mentioned. We cannot get super-regional neurophysiology for our patients. They say we're not funded to provide it from your health board, but we don't have enough. We've got a shared waiting list for children and young people as well as adults. We have limited video EEGs. I would love there to be defined criteria where I can refer to the CESS service without just adding obstacles when there's no more neurophysiology. But I'm using the opportunity to comment on the pathway by also saying we're team. We need good neurophysiology resource. We need prompt investigations to specialist neurophysiology. What would you say to me that I can do?
Ooh, it's a tall order. I have to say, I have not, when I say there are challenges within the CESS centres, neurophysiology is one of those challenges. They are, there are some of us who sort of dual trained and have worked in neurophys, but actually neurophysiologists are a very valuable resource, as is video telemetry. So video telemetry has been based in the surgical centres, but actually there are a few other centres. And it's not only for surgery that you use video EEG for. And for example, in one centre, there's one neurophysiologist reporting on adults and paediatrics doing all the stereo EEG. That's not feasible in the sense that you need backup if they go on holiday or they become unwell. So, it is a real issue that we are going to try and address with the British Society for Clinical Neurophysiologists, because training and getting appropriate neurophysiologists in post is important, as with all the specialties. But I know it's a particular bottleneck for us. For you in Wales, I think I know people get exhausted with trying to advocate for things, people are busy. But actually joint, case examples, joint advocacy to say this is not appropriate, utilising base data from other places, even England and even Scotland, to say this is what's happening, this is the way forward. There is now a cost-effective paper that came out of the NICE guidance to indicate that surgery is much more cost-effective. It only has adults, but there's no reason why that shouldn't be the case in children as well. So that will be out. I think it's just been accepted for publication. So that will be as a look at this, epilepsy surgery is the way to go. So it's actually collecting data to take to your policymakers to say, or commissioning to say, this really has to be, we have to have a way in. And I presume it would be to Bristol for you to go.
I think it's up for debate, actually.
Right, okay.
At the moment, some come to London.
Yes,
some go to
Bristol, yeah.
Yes.
It's just for the people online. That's why the microphone's used.
Right, sorry.
Yeah, that's right. Yeah, but yeah, I appreciate it, and I'm happy to talk about it with you afterwards.
Thanks, Helen. So I think there's a few questions online before I come to Richard.
Yes, I can say, was there one about what advice would you give for general paediatricians trying to refer to CAS with neurology input? We say
as in, if they weren't being able to get through the neurologist, then I think that you could refer direct, copying in your neurologist, actually, she says. I'm going to get shot for this. I think, referring direct to your CAS service, copying in your neurologist. So I think most of the CAS services would take referrals from paediatricians with an expertise, but then copying in the neurologist so they know. But I think that would be appropriate.
And it certainly open up the dialogue between the tertiary centre, the tertiary neurologist and the CAS centre as well, if they're included.
Yeah.
yes. And then on the feedback that you've got for the potential barriers to referring, were tertiary neurologists consulted on that to gather that feedback? As
in the Open UK survey?
Yes, or any of the ones to just how you got those barriers to referrals?
They were actually from the survey that was conducted by Elaine Hughes and Jonathan Holland, thank you, which was a survey that went out to all the Open UK members in order to try and get that feedback.
Okay,
so that would have included tertiary as well as paediatrician with expertise, yeah.
Open UK proudly represents the epilepsy community both at tertiary and secondary level.
Yeah, thank you.
Say, how often do you have CAS MDT meetings in each surgical centre? And then do you know the average current waiting times for surgery once families are on the pathway? Okay, so you have to, well, first of all, how often are meetings? I mean, in London, they're weekly. And in some centres, I think it's bi-weekly, so every 2 weeks. So it's either a week or every 2 weeks. And those who have it less frequently usually have longer meetings. So, they are quite frequent. We have a national MDT. So that means all 4 centres join virtually once a month and discuss complex cases. And so when a centre's been asked to get another opinion, then they bring it, or they feel they want another opinion, they bring it to that national MDT, and we all discuss it as a team. What's the other question? What are the waiting times once families...
That is quite variable, and it depends where you look, okay? I think, if you're looking for the pre-surgical evaluation, it depends where the pinch point is, and it can be anything up to 9 months. But actually, if there's a clinical need for it to be quicker, then that, very young children, for example, usually move through the pathway quicker. And at the moment, unfortunately, the wait for surgery can be up for, once the decision's made, can be up for 6 months in some centres. And that's something we're desperately trying to bring down. And that's been all sorts of reasons for that, such as, strikes and goodness knows what else, and beds, etc. But we're trying to bring that down. One of the discussions for the new service specification is, should we have targets in order to know whether we should be aiming for this point in time for evaluation, and indeed, to say between being referred to surgery is probably not the way to go, because there's lots of things that can happen. It may take longer to the evaluation because it's a more difficult decision. The family may decide they don't want it at a point of time. So it should be from surgical decision by the family to surgery should be the key time that we're trying to look at.
That's what we capture in Scotland, because you say it's a very variable feast, that whole time referral in the service to when you actually get to the point at which your family have seen the surgeon and then said, we want to go ahead. And that's the point the clock starts in Scotland.
Yeah.
I'm going to leave the last question in the room from Saskia. Is that okay?
Yeah. Do you think there's misinformation within the general public and those who have epilepsy regarding epilepsy surgeries?
Yes. I mean, the thing is, for anybody that we suddenly say, let's consider surgery, it's frightening. Okay, I accept that. Brain surgery, oh my goodness, why are we discussing that? Surely that's dangerous. So there are misperceptions. And I think, we know now that neurosurgery is much safer. If it's planned, it's much safer. And, the risks actually, even though you're thinking it's on the brain, are no more than a major abdominal surgery, which people would be surprised about that, if we've carefully evaluated them and we've looked at all the risks and benefits. So, yes, there is, because it's brain surgery, and it historically, it's not had good press, I have to say. If we, look back in history, brain surgery was undertaken for not very good reasons. So, really that has come through and is still talked about. And that's another thing that we have to advocate for, that it's not what it was 40 years ago.
Thanks, Helen. I'm just going to bring it to a close. I know there are probably people who have unanswered questions. If you're in the room, you'll be able to ask Helen. I think if there's anything pressing online, the guys here can let us know. We'll take it to Helen to send the answers back. So, thank you very much.